So I said the first degree is like normal sinus reading. The only difference is that prolonged PR. Please, few minutes. I will share the screen now. The only difference is what? The prolonged PR. That's the only difference. Chai, it's not even sharing. The only difference is the prolonged PR. Sorry. Hey, who sent me now? That's what I use. Or it's not taking it. So it's a lot of work. So we're talking about the first degree. I'm so sorry. It wasn't opening because um of the password. So this is the first degree. As you can see, it's going to look like normal sinus reading. Like I told us yesterday, it's going to look like what? Normal sinus reading. However, the PR is elongated. See this place. I'm sure you can see my screen. If you cannot see, let me know now. I'm sure you can see my screen, but if you cannot see, please let me know now. Okay, so you can see this level. Now from here, if you zoom it at your hand, you have 1, 2, 3, 4, 5, 6, 7, 8, something like 8. And if you multiply 0.04 times 8, you'll be having 0.32, confirming the fact that PR is unnecessarily long. And because it is long, it's going to be consistently like that. That makes it a regular reading. Consistently like that. That makes it a what? A regular reading, because as you can see, but you remember my warning. Please don't mix this up as normal sinus reading. So take your time, look at your PR. That's about that. So I was talking about second degree when everything went off. So this is story about second degree. In second degree, there is a missing, let me use the word missing QRS complex. In second degree, there is a missing QRS complex, okay? Either type 1 or type 2, you will see that QRS is what? Is missing. Now, what precedes the missing is what we need to look at now, okay? For the first type, this type 1, before there will be a missing QRS, you will see the PR longer than normal, get longer again, then QRS will now be missing. Like normal supposed to be 3 to 5, you will now see the PR. Okay, look at this. Look at this. This is this green marker is for P. The golden marker is the space occupied by the PR. You see, this is shorter, this is longer, this is longest. Okay, and when you get here, you start looking for QRS. When you get here, you start doing what? You start looking for QRS here. And that is the problem with type 1. PR progressively gets longer, and thereafter you'll be looking for what? QRS. So PR gradually elongates until a P wave is completely blocked. So here now, the SA node has initiate impulse, and that's why you are seeing the atria contracting. But P wave is already, but AV bundle has been blocked. It cannot transmit impulse to generate the QRS. That is why one QRS is missing here. And that is the reason why you are not seeing the PR. Because what? The QRS is missing. So the PR is also what? Missing. That is first degree. Do we understand? That is the first degree. You hear something like longer, 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 missing. Longer, 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 missing. Like QRS will be missing. And it's going to be consistently like that throughout the reading. It's going to be consistently like that. Eventually, this is not a regular reading, because where the missing occur will be longer than all other places. Do we understand? Okay. Now, let's go to the second degree. In second degree, although there will still be a missing QRS, but what precedes the missing for second degree is not the same thing that precedes the missing for first degree. In second degree, the PR does not have problem. The PR is constant, normal. Look at it. If you can zoom it at your hand, you will see that this is normal PR. If you can zoom it at your hand, you will see that this PR is between 3 and 4 boxes. Look at how the PR look fine. Okay? But see, P QRST, P QRST, P QRST, then P. Where is the QRST now? This is missing. And that makes it a second degree. It is called Mobit type 2. Now, this is complete. There's no problem. This is complete, no problem. This is complete, no problem. There is no traces of there is an impending problem. According to the first wave, the second wave, the third wave, there's no traces of an impending problem. Suddenly, problem occur. We didn't see ventricles contracting. Then thereafter, e pick again, then it occur again. So now, if you are to answer a priority question between the second degree type 1 and second degree type 2, who would you now see first? A patient has second degree type 1, another one has second degree type 2. Or they just show you the strip and they say, this is one, this is a strip. This is another, sorry, this is a strip. Oh, it was going ahead. Sorry. So this is one, okay? Then going back to the first degree, this is another one. Who are you going to see first? I'm expecting chat to reply. Who would you see first? Can you hear me? You are not responding. No. Who would you prioritize out of the two? Like, is my voice good today? I cannot see our responses. Okay, type 2, not scanning. Thank you, ma. Who else is going to prioritize type 2? Who else is second degree? Okay, who else is prioritizing type 2? Who else is prioritizing type 2? So others are not responding or their network. So you are going to prioritize this second degree because first degree is giving you traces of problem. You can actually try to do something. But second degree becomes a sudden onset. And this exam does not play with what? Sudden onset. So you will attend to second degree first. You really don't need to know what makes the QRS to be missing. You really don't need to know. You just need to be able to identify it like that. Like first degree PR continuously or progressively gets elongated until a QRS is missing. Why for second degree, there's no problem with the PR. PR is constant, normal, and yet suddenly a QRS is missing. So by the time you see normal PR looking like sinus rhythm at the beginning, then along the line, we are looking for QRS. So where is it? Trust me, you're having 2 in your hands, second degree type 2 in your hands, okay? Another feature of all the heart block is bradycardia. Another feature of all the heart block is what? Bradycardia. So if care is not taken, blind, you say, oh, this is 40, bradycardia. This is not bradycardia that is sinus. This is bradycardia that is problematic. Okay. Second degree type 2. Now let's go to third degree. Third degree is also called 2-1 block. You might have had the patient is having 2-1 block. Yeah, it's also known as a third degree heart block. This one after ventricular fibrillation, this one will take priority. Okay, after ventricular fibrillation, tachycardia, this one will take priority. You know why? This one can still wait, will not die immediately compared to the fibrillation and tachycardia. Fibrillation is always number one, then tachycardia, ventricular tachycardia, then you come to complete heart block, and that is failure of conduction from atria to ventricle. It's not even doing it small small, it's not conducting at all. In this situation, write in your jotter, complete heart block, everybody goes his own way. P is doing his own, QRS is doing his own. You know, I taught you at the preliminary that P must precede QRS, meaning they are working together. Okay. For complete heart block, P does not have to do with QRS. There is excess P because P is just firing, QRS is firing whenever it feels like. So how would you know this is a complete heart block? That's where the name 2-1 comes in. You might see 2 Ps before 1 QRS. That is where the name 2-1 comes in. Like, look at this one. This is, let's say this is P, QRS, T, then another 1, 2P, 1P, 2P, then QRS, T, another 2P, QRS, T, another 2P, QRS, T, another 2P, like that. And that's what give it the name 2-1 block, like 2P, 1 QRS block. Now you could say that all of this trip that is needed to know for NCLEX, not to become a cardiologist, all of this trip, they are not the same. And I have tried to, show us specific sign to look for to know which is which. In art block, first degree looks like normal sinus reading. Only PR is consistently longer. Like if the first PR is 7 boxes, all the PR in that strip will be 777 boxes. In the second degree, it's a problem of missing QRS. A QRS must be missing. Second degree. So once you hold it and you see QRS missing, the next thing you want to start looking for is what happened before the missing, before the QRS is being kidnapped. It might be that the PR is getting longer, longer, longer. That's Wenke back, first degree type 1. And it might be that the PR has been constant, there's no problem. It was even looking like normal sinus reading. Along the line, QRS gets kidnapped. That is second degree. And that will take priority over the first degree because there is a sudden disappearance of the QRS of this patient. Like suddenly the ventricle refused to contract. That's what it means. Now, for the third degree, there's no missing QRS. The QRS is there managing, the ventricle is just managing to contract, even though it's not in response to the P wave. So P wave is contracting, QRS is contracting, and that is what gives its name 2-1 block. 2-1 block is the sense that 2P before 1 QRS, 2P before 1 QRS. So making this reading a regular reading. Third degree block is a regular reading. And like I said, this is not a situation of atropine. Atropine may rather kill this patient from some other nerve activation problem. This is a problem of pacing. Atropine will not raise this pulse, but pacing will too. Either external, excuse me, atropine will not raise this pulse, but pacing will too. Either with immediate transcutaneous pacing or with permanent pacemaker. Okay, anyone will raise the pulse of this patient. You expect this patient to be having fatigue, like activity intolerance plus plus, because the cardiac output will be so low. Like see this strip now is only 40%, 40 beats per minute. Okay, 50. It's only 50 beats per minute. So the cardiac output will be so low. So the patient may be complaining of chest pain, tachycardia, activity intolerance, fatigue. And another deadly thing that can happen is ischemic stroke, because the blood that is not having enough force to contract, there will be pull. By pulling, you have clots. From clotting, that can detach and block any vessel in the brain. So the patient is at risk of ischemic stroke. So if you look at your question, case study, they might start from AV block, third degree AV block, and may end on ischemic stroke. So the last thing I want to talk about is, okay, this is another diagram. You could see it. You could see how many P you are having before QRS. Yes. So this is 40 pulse. Okay, it's 9, 10, 11, 12, 13, 14, 15. So it's 30 boxes. So this is 40 pulse. You can understand. So this pulse is even a lot lower. Okay, and we have talked about paced reading. Once they put pacemaker, how the ECG will look like, I've shown us. Now the last thing, okay, before we go, this is the comparison of the three. The first one, which is Wenky back, you can see the elongation. Okay, see this place, see this place, see very long, and see QRS missing. For the morbits, equal distance, equal distance, equal distance, QRS is still missing. And for the 2-1 block, one P, another P, one P, another P. So just like I've explained, okay? Now the last thing I want to talk about is pulseless electrical activity. In asystole, there's a cardiac arrest, heart is not responding at all. In pulseless electrical activity, there's a cardiac arrest and yet ECG is showing some movement. Although when you touch the radial pulse, you cannot palpate anything, meaning that the activity of the heart is not producing a pulse. That is what it means by pulseless electrical activity. The activity of the heart is not producing a pulse, okay? That is what happened. In this situation, you will not shock the patient. What do you want to shock? The heart is not producing any pulse. It's not, the activity is not productive. So you are not shocking the patient. No. Just like asystole, no need for shock. PEA, no need for shock. No. You don't defibrillate. That's what I mean by shock. Oh, so basically it's CPR and epinephrine, just like in asystole. Then there are some 6H and 6Ts that could be the cause. So treatment may be given just like hypertension and hypoglycemia, hyperthermia, hypoxia, toxemia. There are 6 of them. Okay, so this is how it will look like. You can see that there is no too strong P. The QRS is just somehow, okay? No P here. Then the QRS is just somehow, no T. You can see it. So when you see it like this, you can't find T, you can't find P. QRS looks like premature ventricular contraction. You know you are dealing with pulseless electrical activity. QRS looks like premature PVC. No P wave, no T wave. PRS looks like PVC. Just know you are dealing with what? PEA. So this is the end of our class. Let me reiterate as I started by saying ECG is an interesting and very sweet course. If you have the right keys, it is very easy to interpret. You will see that if you had been consistent either with on-site or rewatch, you will know that it's not difficult. Okay, so at Endless Keys, we deliver the right key with strategies. Trust me, strategies never had anywhere. That's what we do here. And then we try as much as possible to ensure that you pass your exam once. Won't you rather join us? So this is what we do. And this is the end of the class. So as I promised, I'm going to drop this document, but I cannot remember the password. Oh, I will look for it anyway. So let me take our questions. You can drop it there. You can drop it on the WhatsApp group, whichever. I said I'll be here to take our questions. NCLEX, ECG. What other question can you ask me now? Oh yeah, now ask me any question about anything. If I cannot answer, I will tell you. So do we have any question? Okay, somebody sent an ECG to us on the, okay. Is the person in class? The person that sent this ECG, is she in class? Let me ask her. If she's in class, then let all of us go and look at this ECG. Now, it is called 12 lead EKG. However, okay, she's here. Thank you. However, 10 electrodes will be attached. It is called 12 lead EKG. However, 10 electrodes will be attached. Where are you attaching them to? The this place, the anterior forearm, the two will be here. One, two. Then I can't raise leg. Oh. At the you know that your lateral medial malleolus, you put one there on both feet. Okay, I can't raise leg. So that will be four. The remaining will be on the chest. V1, V2, 3, under the breast, 4, 5, 6. Let me show you. At least I can show you that from here. You have V1. Okay, the camera is showing me in reverse. Okay, V1, okay, V2, V3, 4, okay, 4, 5, 6. Then 2 on the hand, 8, 2 at the leg, 10. Do you understand? Okay, so that is the 10. When you have a strip like this, it's a kind of strip that have put every the reading at every point into consideration. Okay, let me show you the diagram of what I'm saying. I think I have the diagram so that it will be closer. Yeah, I do. Few minutes, please. You will see it on the WhatsApp. I cannot bring it to the YouTube. You'll see it on the WhatsApp. So this is the diagram of places that those 10 electrodes will be attached. So when you see a big strip like this, what happened is they demanded a printout of activity of everywhere. So please kindly look at the diagram in your on the WhatsApp page, please. Look at it. Have you seen V1? Have you seen V2? Have you seen V3, 4, 5, 6? You understand? Then RA, LA, RL, LL. Have you seen both of them? You have seen where I'm calling media malleolus. That's shootout that you can rub on each other. That shootout at our ankle that you can rub on each other is called media malleolus. Let me type it. Media malleolus. Yeah. So that's where you put it. The one outside is lateral malleolus. Okay. Now you can see. Now, if you now look at your diagram, you'll be seeing something like V1, V2. I tried to show us that so that we know the implication of the V1, the V2 that you are seeing. Ordinarily, this is looking normal, like you said. This is looking normal, like you said, but there are some delays somewhere. It's also looking like a fib somewhere. But if this patient has hypertension, like I told us, we are not cardiologists. There's a way cardiologists interpret this thing because the products sometimes has to go with the underlying condition. If this patient has hypertension, you might have a kind of ECG like this. If this patient has had hypertension, 40 years does not is not really the reason for this ECG, but underlying condition. underlying condition. What did your cardiologist say? Has cardiology read it? This is looking so inconclusive. Nurse Latifat, has cardiologist read it, ma? It's showing me something like AFib somewhere. As you can see that fibrillatory wave. Oh yeah, ma, what did they say? Oh, it's showing something like AFib. You just happen to see it. Hey, yeah. Where did you see it, ma? Age is 73. Oh, the age of this patient is 73. The age of this patient, see now, is 73. Is 73 years at the first axis. So this is showing something like AFib. You can see the fibrillatory P wave. And if you look at it, at least at the AVR and V1, you see that there is no distinct the T wave is not looking so distinct. At the V5, that's the lateral side, V5 and V2, there is small hope, but you see at the aortic side is fibrillating, is fibrillating. But this one may not show any symptoms, and the patient may be having, what's the pulse? Is this even, how many strip is this? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. No, this is not 6 seconds. So you have 1, 2, 3, 4, 5, 6, 7. The pulse is 70. They might just say they should go and be managing baba at home because of the age. You know, as you age, the cardiac activity reduces. I don't know if you understand what I'm saying. You send part of the reading in WhatsApp. Okay, let me see. Thank you, ma. So as you age, you will see that the cardiac activity you know, I said that it might just be normal considering the age. It might just be normal considering the age. Because you don't expect that heavy pump like I have. This is 73-year-old. Might just be normal. That was the first thing I said. So, like I know Bukabi, it might just be normal considering the age. Although the push is not as strong as we want it. Please, if you are able to follow up when the cardiologist read it, let's have it, ma. Okay? Very well. Hello? Can you still hear me? My network is saying unstable. Can you still hear me? Okay. I've operated the machine very well. What happened is, as soon as you are done, the machine prints this out. Okay? And in the course of it, because I know how to read it, sometimes when I print it out, I look at it, I may see some artifacts. There's something called artifacts. Artifacts. You can have artifacts in ECG. You can have artifacts in spletimograph. That one, they use it to measure respiration. Spletismograph. Yeah, spletismograph. That ones, they use it to measure respiration. Plethysmography. That's the spelling. Okay, you can have it in the one we use to measure SpO2. That's the spelling, plethysmography. They use it to measure respiration. You can also have it in the one we use to measure oxygen. I've forgotten the name now. Activa simply mean movement error. Movement error. So what I was saying is, where when I was working where I was doing the ECG machine, once I print it out, because I could read it, I can see Activat readjust the legs. If it's the one on the hand, if it's the one on the chest, I readjust the leg and reprint. You understand? So usually by the time the result is printed, I can have um a good conclusion. Many people that operate the machine, they are not cardiologists. You will see that when you are done doing it, they will say cardiologists will still have to read. Cardiologists don't operate the machine, and not many people can read. So once they print, they send it, but once cardiologist sees it, they know how to pick out the artifacts. Okay, so there's something called artifact, and that is movement error. There's a way it looks. Even when you are doing CTG, cardiotocography, like that one you use to measure the heart breath of the baby, you can have artifacts there. It simply means movement error. So it might be here too. But like I said, the first thing, it looks like normal to me, although there are some fibrillatory wave in between. Considering the age, the baba is fine. Any other question? Ma, did I answer your question, ma? Did I enlighten it? At least you're able to know what V1, V2 is all about. I think it's an added knowledge. So any other question? If there's no other question, we can be going on. So did you enjoy the ECG class? Is the 7 days free class? Does it worth your time? Does it worth your data? Give us a little feedback before you go now. Just chat. Does it worth your time? Does it worth your data? Did you learn anything? When you hold your ECG strip now, do you know what you are looking for? Is the bearing better now? Who is speaking to me? Who is chatting for me? Oh, thank you so much, ma. Thank you. If you don't mind, I would want to receive. Yeah, thank you so much. Not okay, Kuncho. Thank you, ma. Thank you, everyone. If you don't mind, if you can just do 1 minute short for me to put on this YouTube about what you have learned during this ECG class. Yeah, go and watch the remaining, sis. Go and watch the remaining. It's still like the same thing, okay? And if you are preparing for NCLEX, if you don't mind joining us, we give a quality training at NCLEX case. Okay, I'm happy having you here. Thank you for being part of my birthday this year. If you have not subscribed, you have not paid my birthday price. Oh. My birthday gift is still in your custody. I love you.